people join in, or let's say 1 or 2 minutes.
All right.
And hi, Nicole. All good?
Everything's good. It's getting a little quiet around here as people are preparing for the 4th of July holiday.
Oh, yeah, right.
Yeah,
Is it like in Germany, Germany is famous for these bridge days. So whenever there is a holiday,
the Brückentag.
uh,
Yeah.
on a Thursday, so typically Friday is considered like a soft holiday for everybody anyway.
It's similar. So it's almost the opposite this year. So the 4th of July is on a Friday.
Hmm.
And so it makes a long weekend. And I think that's
Yeah.
causing a lot of people to start heading out a little early to kind
Yeah,
of
yeah, yeah,
extend
yeah.
the weekend. So I've been noticing every day here at the office, it's a little quieter and a little quieter. So I expect it to be totally dead by tomorrow. But that's okay.
So, yeah, here currently in Germany. So I'm in close to Berlin, and it's very hot here, but
Oh, yes.
probably same in Heidelberg and in Münster, right?
Oh, yeah.
Yeah, we're
Definitely.
full-time summer. Okay, so Ali, if you don't mind, if you could get started and share your paper on the screen, and Lukas, you can share that a paper that other people cannot even see yet. And we have already. Hi, David. David Blumke is already on. Julian Lütgens also has done a lot on myocardial disease, and so we have already some people who will hopefully contribute later to the discussion. So, Ali, thank you very much for joining. So you published recently a paper in JCMR called Diagnostic Value of Bone Scintigraphy versus Cardiovascular MR in Cardiac Amyloidosis. This is our topic today, cardiac amyloidosis. I think this is a very interesting topic. So I say this unprotected. Since years, I think I don't understand why people are still sent to nuclear, but you may convince me otherwise. But I think with MR, we have a wonderful tool to detect amyloidosis. And as Lukas will show us, maybe even do more than just detecting amyloidosis. But Ali, I don't want to take more of your time. Walk us through your paper where you compared bone scintigraphy with MR in cardiac amyloidosis.
Yes, and thank you, Matthias, for the introduction. Well, actually, our starting point was the same as you mentioned. In Germany, you are forced to perform bone scintigraphy in order to be able to start a patient on a specific medication. CMR, even if it's clear-cut, is not sufficient to start a patient with cardiac amyloidosis on a specific cardiac amyloidosis therapy. And this was our point. So we asked ourselves, if we have patients with a clear-cut CMR pattern indicating the presence of cardiac amyloidosis, what are the respective or the correlating bone scintigraphy results? And therefore, we performed a retrospective study. So we looked into our very huge database and looked for those patients who presented to our institution with a suspicion of cardiac amyloidosis based on red flags, clinic, etc. And where we had performed a CMR study, including CINA and late cut at least, and where we have seen a typical pattern of cardiac amyloidosis. In addition, we also included patients who had a clear-cut bone scintigram at presentation, and clear-cut bone scintigram means that they had a Perugini score of 2 or 3, and in whom we additionally performed CMR in order to better assess the extent of cardiac amyloidosis. So if we quickly go to the figure 1, this is the flow chart. So finally, we included 128 patients into this analysis, and all of these patients had both a CMR study and a bone scintigram. And we found that there were patients that had a positive CMR study, and positive means clear-cut late enhancement pattern indicative of cardiac amyloidosis without a differentiation whether this is AL or ATTR. This differentiation was made based on the measurement of serum and urine light chains. And these patients had also a positive scintigram indicating a Perugini score of 2 or 3. So 108 out of 128 patients had, let's say, a match in the respective modalities. But we had 23 patients out of these 128 where CMR was positive, indicating the presence of cardiac amyloidosis, but scintigraphy was negative. So negative or inconclusive. Negative means Perugini score 0, and inconclusive means a Perugini score of 1. And we had 2 patients where CMR was, let's say, termed as negative. It was not really negative, but the pattern was not clear enough in order to say that it is positive, and in whom scintigraphy showed a Perugini score of 2 or 3. So there were 2 patients with such a mismatch. In those patients where we had such a diagnostic mismatch, we tried to get additional biopsy in order to get a biopsy-based diagnosis. And you can see this here. Out of these 23 patients with such a diagnostic mismatch, we performed biopsy in the majority. Only 5 patients did not want to undergo biopsy, but we had biopsy results in the remaining ones. And you can see that within this group of 23 patients being CMR positive but scintigraphy negative, there were 8 patients with AL, 8 patients with ATTR that were missed by bone scintigraphy, and in 2 patients, the pathologists told us that there is cardiac amyloidosis, but due to limited specimens, they were not able to make the differentiation. On the other side here, we have 2 patients where CMR was negative and scintigraphy positive, and the final diagnosis was made based on additional light chain analysis, and these 2 patients were found to have ATTR. So if we take a quick look into our patient cohorts, we had 120 patients in total. 8 patients were found to have light chain amyloidosis. 113 patients were found or to have ATTR, and we had 2 unclassified cases. It was a old cohort, and you can see the distribution of the renal function, the Perugini score, the next score, etc. And you can see that the BNP value is quite high in all of these patients. But the interesting results were the comparison of the final findings compared to each modality. So when we looked at those patients having a positive CMR result and having any subtype, so the total cohort of 123 patients looking at ATTR and AL, we found that CMR was positive and indicative of the presence of cardiac amyloidosis in 98.4%. And in the same group, bone scintigraphy was positive only in 105 patients, showing a lower sensitivity. When you exclude patients with light chain amyloidosis, of course, the sensitivity of bone scintigraphy increases, but is still lower compared to CMR. And I will quickly show you this figure as an example. So we had patients with a diagnostic match, positive scintigraphy, positive CMR, clear-cut CMR. We had patients having a negative or inconclusive bone scintigraphy result, so no relevant tracer uptake, Perugini score either the 0 or 1, but in whom we had a clear result based on CMR. This is a clear pattern of cardiac amyloidosis. And actually, there were 2 patients having a positive bone scintigraphy, but a negative or inconclusive CMR. And if you look at this image, you can see there is some late enhancement here in the lateral wall and the septal wall, but it was not clear enough in order to indicate that this is a clear-cut CMR-based case. And the major conclusion of this study was that we said, okay, if you have, first, CMR has a substantially higher diagnostic yield for the diagnosis of cardiac amyloidosis. If you look at a real-world cohort, including both ATTR and AL, And I guess it's even more important to say that in case of a clear-cut positive CMR result indicative of cardiac amyloidosis, there is no incremental diagnostic value of an additionally performed bone scan. And I'd like to emphasize this. That's it, Matthias.
Fantastic. Thank you very much. So this is obviously for some probably provocative, and for everybody, if you have questions, just post them in the chat, or just unmute yourself or raise your hand digitally here in the tool. So the questions I have, the two questions are, when you look at there are only few patients, of course, where I mean, only two basically where kind of nuclear was clearly better. So you showed this one case where you still had late enhancement. It was not what we typically considered. However, to me, it looked like the removal of the gadolinium from the blood pool was also similar. I don't know what your settings are, whether you use a gray a late gadolinium enhancement where you artificially also suppress the signal of the blood a little bit. But can you say why were these two missed? What happened there?
Well, for this study, we said that we would like to have a clear-cut pattern, and clear-cut means that you have this classical late gut images performed, let's say about 10 minutes after contrast administration, and you have a diffuse pattern mostly in the basal parts, mostly starting from the subendocardium and extending at least to 3-4 segments in this basal slice. What we do is indeed we perform so-called black blood images even after 10 to 15 minutes in order to delineate the subendocardium compared to the cavity better in order to see the pattern better. But it should be emphasized that we did not consider, for example, mapping and ECV values for this analysis. Of course, if you would add mapping and if you would look for an ECV value, let's say more than 40% in addition, this may increase even your diagnostic yield that you get from CMR. But for this analysis, we didn't do this, and we just looked at our late gut images.
Yeah, so that was actually my next question. What about mapping? And I'm sure you have applied mapping clinically since. So what is the value that you see? So you already indicated you expect that the diagnostic accuracy may be further improved by the application of mapping?
Yes, in principle, yes. So in our patients with a suspect of cardiac amyloidosis, we always perform mapping, T1 mapping and T2 mapping and post-contrast T1 mapping in order to calculate ECV. The problem is if you have a advanced disease stage where the late enhancement pattern is clear, then you will receive ECV values of up to 80-90% per segment or globally. But if you have an early form of cardiac amyloidosis, not a really thickened myocardium, but just 11, 12, 13 millimeters, and if you just have a slight signal of late enhancement, then your ECV values may be between 30 and 40. And in this range, it is difficult. It is still difficult, even with mapping, to say, well, this is amyloidosis. It could be something else. Therefore, I would use this cutoff of, let's say, about 40% for ECV in order to be able to say this is a link or a hint for cardiac amyloidosis.
So you think that the late gadolinium enhancement, in your perspective, still has a slightly heavier diagnostic weight than the mapping and the ECV?
Yes, we first look at the late gut pattern, and if the late gut pattern is clear, then everything, or then you can be quite sure. If the late gut pattern is not clear, if you have an early form, then we also take mapping results into consideration. But to be honest, if you have values between 30 and 40% for ECV, if your late gut is not clear, we approach to biopsy. We perform invasive biopsies in order to get a clear-cut result.
Okay, thank you very much. Last quick question. Do you think these results are also applicable to less experienced centers? Because you, of course, you have a lot of experience. You have personally done a lot of research on amyloidosis. Do you think these results can be translated to centers who see an amyloidosis patient a month?
Of course, because late gut is a robust technique that is used in every center. So it's not a really specific technique that is just used in Münster. It is used everywhere. Well, you will need some experience regarding the interpretation of your images, but you will gain, I guess, very quick this experience that is needed. And therefore, every center can do this and can assess the presence of cardiac amyloidosis. And in case there is some, let's say, there are some unclear findings, then we still go and perform bone scintigraphy. So we do not say that we should not perform any bone scintigraphy. Bone scintigraphy is a blessing regarding the diagnosis of cardiac amyloidosis. It should be used in addition to CMR in unclear cases. But my point is, if you have a clear-cut CMR result, then actually you don't need it.
I think that's a great takeaway. So if you have a result that makes you confident on a diagnostic level, then it's a good clinical rule. Then the threshold for another scan to just make us feel better as doctors should be fairly high. David, you raised your hand.
Yeah, hi. Ali, this is a very, very nice study, very strong, really supports what a lot of people are doing, just using LGE and the T1ECV. You never know what's going on with that. But one unique aspect of the study is also you have an incredibly high pretest probability, which of 128 patients, it looks like 123 might have had amyloidosis. So that's a really good record, by your clinicians and folks referring to MRI. How do you think, in our, I'd say at our center, it's maybe 20%, something like that. But how do you account for that super high, selection of people going to MRI?
Very important question. Thank you, David. Well, if you would use the European, the EC guidelines in order to suspect cardiac amyloidosis, you would suspect cardiac amyloidosis in every patient being older than the age of 65 years. And if you would perform CMR in all of these patients, then your yield would be about 5%, 10%, or even lower. So it depends on the red flags that you take into consideration in order to suspect cardiac amyloidosis and in order to decide whether to perform CMR or not. And we in Münster, we have a specific outpatient clinic for patients with cardiac amyloidosis. We are taking care currently of more than 500 patients with cardiac amyloidosis, 90% ATTR. And we did not use the EC recommendations, just age of 65 years, just heart failure symptoms and the thickness of 12. We said we need more red flags in order to consider the respective patient for this retrospective analysis. And this was the reason that we have a very high hit rate within this study.
Okay, thank you very much. There is another question in the chat, but Ali, I would like you to answer that in the chat, because in the interest of time, I would like to move on to Lukas. So Lukas from the University of Heidelberg. So we moved from Münster in Germany in the middle west to the southwest to Heidelberg. And Lukas is at the University Hospital there, a cardiologist with a lot of interest in myocardial disease. And as a full disclosure, I was involved in this work. This is about the use of MR to differentiate, or not only that, but to detect, but maybe also differentiate between subtypes of amyloidosis. So very exciting work. Lukas, just take it from here.
Right. Thank you very much for the very kind introduction. So yes, as you can see, there's only a first proof. So the final paper will be out in 2 weeks. But I'm happy to share our research there. Basically, what has been said before is that cardiac amyloidosis is increasingly recognized, and I think it's quite more often there than we think. And the same goes for light chain and ATTR amyloidosis, but also for hypertrophic cardiomyopathy. And all three of those are curable. And this is quite important because the current therapy is only mostly a slow disease progression. So it's quite important to detect these diseases early, at an early stage, but that's currently not happening. So that's why we invested in this study. You see here a classical case of cardiac ATTR amyloidosis. As you can see, you have the diffuse enhancement, not only in left ventricle, but also in the valve and the atria, severely reduced myocardial strain, and also highly elevated T1 times. So this is the classical picture we all learn and we all see from time to time. But it's quite important that even in large centers, upon review, you still have 10% of diagnoses that are not true. And you have and as you have seen before, most physicians are referred to other diagnostics as well. So it's quite important to get a head start with MRI. And I think this is why we need machine learning. And this is why we need our study there. So let's look at the graphical abstract here. As you can see, what we did, we collected data from all centers, over 50 centers in Germany. And this is quite important. This is not a collective you've seen before, it's newly collected data. So from all vendors, 1.5 and 3 Tesla. But the diagnosis was for all patients was made at our center. So it's really a professional diagnosis from an experienced center, but CMR data from all around Germany. What we did with these patients is we integrated, in one step, we integrated mostly automated CMR imaging data and standard clinical information. We only included data that was, as you can think, available to a GP. So nothing fancy, nothing advanced. So the idea was really a GP referring somebody to a CMR. That's all the data you have. No light chains in the blood or anything. We put all of that data into a machine learning model to predict the diagnosis. So let's look at our data. We have around 100 patients per group, 100 healthy patients, 94 hypertrophic cardiomyopathy, light chain 95, ATTR 116. It's quite a large table. I just want to focus on two things here. One is the New York Heart Association class. You can see in all groups we have all kinds of disease stages. Only New York class 4 is quite aware. And if you look at the group difference here on the right, of course, there's a lot of symptoms and maybe clinical signs that differ between the entities. Let's look at, for example, carpal tunnel syndrome, which is quite often in ATTR amyloidosis, also apparent in AL amyloidosis. So that is really a red flag, and clearly a red flag, but also something that's not really sensitive to the disease and something that even gets often missed in the history taking. So in the next table is the cardiac imaging parameters, which is quite the large and confusing table, but I want to focus on two things here. One is if you look at all the values we had, it's all stuff you all have. If you look at an MRI, you have the volumes, the mass, the ejection fraction, strain, just the feature tracking strain, and late gadolinium enhancement. And look at the group difference again from group to group. They're quite nearly all, they are all significant. So there are a lot of group differences here. But if you look at the values individually, let's look at global longitudinal strain, for example, 10% for light chain amyloidosis, 12% ITTR, then 12% light chain, 40% hypertrophic cardiomyopathy, and 20% is a typo here, which will be corrected in the final version. So 20% for the healthy. Of course, that is different, but it really doesn't help much if you have somebody with a strain of 12.5. Can't really say because the overlap is quite big. And like these, there are a lot of values that differ a little, but you are struggling as the interpreter to really look at these. And this is where the machine learning gets really interesting because it can look at these values individually. So let's look how we integrate the data. We had 3 data sets. One is everything we had, all basic parameters, age, sex, weight, height. Basic biomarkers, no light chains or anything, just the three lab values here: symptoms, physical examination, past medical history, and ECG findings, just 4 one or no questions, and the CMR data. For the next data set, we try to reduce the included data to just anything a CMR unit anywhere in the world would have. So it's just CMR data, age, sex, weight, and height, nothing more. And even for the third step, we just reduced it to just needle-free, so no contrast agent CMR. And what our machine learning model did was, in the first step, rule out the healthiest from the rest, from the patients, then hypertrophic cardiomyopathy from amyloidosis, and then rule out the 2 subtypes, so AL from ATTR. So let's look at the performance of the model here, further down. So what you can see here is the different steps of the analysis on the x-axis, so healthy versus the patients, hypertrophic cardiomyopathy versus amyloidosis, and subtypes. And here you see all the data sets with every data available. Just the imaging data is the second row, and the needle-free exam is the third row. And as you could see, well, I would argue healthy versus unhealthy is quite easy for every reader. And here we have a perfect distinction in all groups. Hypertrophic cardiomyopathy versus amyloidosis is really an excellent performance there. And even for ATTR versus AL, so for the subtypes of amyloidosis, it performs extremely well, considering that's only automated imaging data and with a machine learning model. So, but we didn't want to stop there. As a clinician, I always want to do something that helps me in my daily work. So this is why we went back and looked at the most significant values that influenced our machine learning model. And these are the 6 most important values that were decisive for the diagnosis of either amyloidosis or hypertrophic cardiomyopathy. And I can't go into detail, we don't have that much time, but have a look if you want later in that PDF. So just combining these 6 values and looking at the cutoff will get you at a area under the curve of 0.89 for this differentiation. So really something that may help you in your daily practice. We just did the same for AL versus ATTR amyloidosis, the same here, 6 values and 2 abnormalities that are quite specifically found in one of the 2. So I hope this can really help all of you in your daily practice and maybe put CMR in a spotlight for cardiac amyloidosis. So thank you very much for your attention. I'm looking forward to questions.
Yeah, thank you very much, Lukas. So of course, the obvious question is, and I'm looking forward, of course, to other questions, the training of the model. So if you train a model with all patients, of course, then your model will be able to detect that. So can you comment on how you avoided that?
That got lost in time. So initially we wanted to use the internal data for training and then the external, so collected from the whole of Germany for validation. But just consider that we only have Philips scanners. So there would be a model that would only have Philips scanners and wouldn't be that applicable to all vendors. So what we did is we did a 70-30 split. So we took all the data together, just a little from the external, a little from the internal for train, and then did a total separate cohort of which was a sub-cohort for the testing. And we did a 10-fold validation to ensure that everything went smoothly. But of course, it needs further validation and further collectives and further work done. Still a work in progress.
Yeah, and for those who do not do a lot of machine learning yet, so a 70-30 split is usually considered, I mean, I don't want to pretend I'm an expert in that, but that's what I have learned already, that a 70-30 split is already a pretty solid way. Many split 80-20, so they trained with 80 and then applied to 20%, and this was 70-30. So this gives some more confidence that the model would be able to detect that in other populations. So can you, or I see Nicole raised her hand, so maybe Nicole, you go first.
Oh, I'm sorry, I didn't mean to interrupt.
No, go ahead.
No, I had a question about the needle-free results. So, I mean, it's always in my very limited experience, but it's always tricky to try to convince a cardiologist or radiologist to drop down a number of sequences. Would it be possible to use, your results to, say this might be impetus to avoid collecting anything with contrast, or, like if you're getting the results that are similar with and without contrast, to say, could we just skip these altogether and throw them out? And this kind of provides like a little bit of data to say you're probably not going to be missing that much if you don't collect those sequences, or is this not yet a conclusion that you can draw from the data that you have?
I think there's a lot of data out there, not only my publication, but a lot of data that supports dropping contrast agent, although I still think it's a wonderful sequence. I think it depends on who you ask. If you ask in a university setting, I think we will all say we love our LGE images, and because they're just beautiful and nice to work with. But I think out there in the outpatients, it's a time issue and a cost issue. If you add LGE, you have the infusion, you have to have a doctor to get the needle there, and you have additional time. That's cost, and I think there you have quite a different discussion if you need LGE. And I think it's far more in outpatients clinic now work with only a fraction of patients who receive contrast agent. I think that's just a reality.
Yeah, and so I have another question, although we're a little bit already over time. You spoke about the so-called features that we all would, as clinicians, also understand and talked about the most powerful. But were there also features that we would not be able to see with the naked eye? So, and what was their role and weight in the model that was applied here?
I think for the naked eye, it's quite. We all have this feeling, this from the experience. This is an amyloidosis or not? And so we can't really tell what it is. And I think it's always nice to put numbers behind that, not only think, but to measure. And then what I found, what is really logical, but which was quite new, is that all the right ventricular measurements, from right ventricular strain to atrial volumes and all that, these are quite specific for amyloidosis because it deposits everywhere. But it was hypertrophic cardiomyopathy, which is mostly in the left heart. So this is something that it's really always, I think it's really nice just to put numbers behind what you see and what you think.
Yeah, and features that were related to the tissue, so that were detected in the cine images, for example. Also, the kurtosis is one of the values, the features that is often put forward in tissue characterization in native MR images.
Yeah. Since we only didn't put the images directly in, but just like the measurements, that so there was a point here, but it's quite interesting to look at, I think.
Yeah. Okay, and there's one quick question in the or I hope you can answer that quickly in the chat. Then it's on the machine learning model, how you picked the best folds, and whether you can talk about some details. Just maybe just a quick question. Otherwise, you may have to refer to the paper and the methods section there. But
so basically. I have to refer to Mitchell here, Venavoy, who was our machine learning man here, who was involved in all that, but it's just a really short random trees model. He, before looked at the data with software he himself invented, looking at, I think, 20 different models, which all assess the problem simultaneously, and then pick the best performing out of, and it was a model that was previously selected and has been tested on real world collectives. So just very shortly, but it's more in the publication.
Okay. I don't see currently Mitchell on the, otherwise we would have asked him. Mitchell, if you're there with another name, then raise your hand. Otherwise, I would like to now, first of all, thank you, both of you, Ali and Lukas, for the excellent presentations about this really, really interesting paper. I think it's really time to tell people that it's time for nuclear to leave the stage here. I know that sounds radical, but I mean, just look at the data. It's just doesn't necessarily make a lot of sense. And the new methods that may come out there, especially machine learning, they may have a game-changing role here. Nicole, are you ready to talk about the next journal club in August? I think on August 6th.
Yes, so hopefully you guys can see the slide at this point. So yes, so we'll be reconvening on August 6th at our usual time. And we have two papers with a focus on fetal MR, so in particular, fetal CMR. So we have one paper, which is actually, it just came out, it's really brand new, talking about how we can use deep learning super resolution to improve fetal CMR. This was done at 3T, but we also have a paper that does something similar, so fetal real-time and CMR at 0.55T. And I think, you know, given the interest in 0.55T and the potential utility of being able to use this larger bore, especially for pregnant patients, I think this is also very interesting work. So yeah, please join us in a month to talk about fetal cardiac MR.
Thank you very much, Nicole. So thank you very much. Again, the work, the question by Amin, if you send an email to the Journal Club, we will forward it to Mitchell, who can then fill you in on the details if you want on the machine learning model. But I think a lot of that will also be in the methods paper, or in the methods section of the paper. So again, thank you very much to the presenters, and thanks everybody for joining and the interesting and good discussion. So I wish everybody a good rest of the day. For the guys in the US, a nice holiday on Friday and a good long weekend, and see you around, and hopefully next month with Nicole on August 6th. Bye-bye, everybody.